good afternoon, and a very good evening from Thailand. Welcome to this episode of RF Breakthrough. My name is Deepali Khanna, and I'm the Vice President of the Rockefeller Foundation's Asia Regional Office. I'll be moderating today's panel discussion. To those of you tuning in from your home or office, a very warm welcome. We're glad you're here, and we encourage you to join the conversation online using the hashtag RF Breakthrough. I'm thrilled to join our panelists today to discuss the state of COVID-19 immunization campaigns around the world, an urgent priority here at the Foundation and for our partners across the globe. Despite a stabilizing supply of COVID-19 shots, inequities to access persist, both within and between countries, and particularly in low and middle-income countries. While 75% of people in high-income countries are fully vaccinated, 20% of people in low-income countries have yet to receive their first dose, leaving many vulnerable populations, including frontline health workers and immunocompromised individuals, without protection. Beyond vaccine availability, experts attribute slow vaccine uptake to demand barriers, including difficulties accessing shots, public distrust of vaccination campaigns, and widespread misinformation that fuels vaccine hesitancy. Nearly 1.5 years into the COVID-19 vaccination campaign, achieving vaccine equity is still far off, yet is key to turning the corner on this pandemic. As new variants like the Omicron subvariant BA.5 and new outbreaks of older diseases like monkeypox highlight persistent gaps in access to health and services, we must do more to get shots into arms across the world. Thankfully, regional health leaders are not backing down from this challenge. Some have even seen early success, finding innovative and grounded ways to build community confidence and ultimately improve access to and uptake of COVID-19 vaccines. So, which tactics have proven most effective? How might countries adapt the models that have worked best, the strategies that get more vaccines into the arms of people and communities who need it most? And what resources are needed to put these plans into action? Before I introduce the panelists, we have a brief message from our partners.
Thank you, Rockefeller Foundation, and thank you, moderator, for this opportunity for me to add my views and experiences to this discussion, an episode of the hashtag RF Breakthrough Conversations on Global Vaccination Bright Spots. My name is Boniface Hlabano. I work as Regional Manager for AMREF Health Africa under the Global Health Security Unit. Part of our current work is to support COVID-19 vaccinations in 27 countries in East, West, and Southern Africa. The aim is to help these countries to achieve the target of 70% of their people vaccinated by the end of 2022. While there are still challenges of COVID-19 vaccine supply and delivery, especially to last mile areas or countries, the biggest challenge really is around low demand and uptake. This is characterized largely by vaccine hesitancy, delayed acceptance, or in some cases, blunt refusal for vaccines by a significant number of people. For example, in Africa, 680 million doses of COVID-19 vaccines have been received from different sources, but only 57%, or 384 million doses, have been administered. So the main issue really is the lack of trust or distrust in the health system, which has definitely impacted vaccine uptake in Africa. Some of the reasons for lack of this trust are the use of traditional top-down approach, which was used by many countries in the early days of COVID vaccination activities, where it was like an instruction from authorities, from Ministry of Health for people to get vaccinated. And this led to resistance and in some cases, complete rejection of vaccines in some settings. This mistrust by the public on health systems is also found to be quite low in those areas where even some health workers are not willing to be vaccinated themselves. Of course, there are issues of infodemic. the negative social media information that really goes around, spreads rapidly, some religious teachings, some traditional beliefs. All these have driven distrust in vaccines in many countries. However, what we've found in a number of what we may call our bright spots over the past 2 years, in the last 2 years, is really the use of mobile vaccination clinics. This is a specialized and targeted approach where vaccine teams go out to look for people. This is where we're saying vaccines are looking for people, compared to the previous approach where people had to go out and look for vaccines. We have seen this work in countries like Uganda, in Kenya, in Tanzania, in Namibia, where these mobile approaches have, in some cases, doubled or even tripled numbers of people vaccinated compared to using the static sites where people have to walk in. So we are quite energized as AMREF. We are very excited to be working with Rockefeller Foundation and other partners to ensure that vaccine inequities in Africa are addressed so that countries may achieve the WHO targets of 70% vaccination coverage. We remain resolute, excited, and committed, and our mission remains the same. No one is going to be left behind until everyone is fully vaccinated. I thank you.
Thank you so much. I want to now welcome María Moreno de los Ríos, Senior Program Manager for the Amazon with Hlabano, an organization working to promote marginalized voices while strengthening civil society. Maria has more than 15 years of experience in international socio-environmental issues. As a Senior Program Manager for Hlabano's Latin American region, she supports the Amazon Indigenous Health Route, which aims to promote structural changes that reduce the impact of COVID-19 on indigenous populations in the Ecuadorian, Peruvian, and Brazilian Amazon. Maria, thank you for joining us.
Thanks very much for the invitation. Buenos días a todos y a todas.
And Gregory Johnson joins us as the co-founder and CEO of mPharma, a technology-driven retail pharmacy operator working across 9 countries in Africa. mPharma solutions portfolios include inventory services, primary care solutions for community pharmacies, and data analytics. Under Gregory's leadership, mPharma forged a public-private partnership with the Ghanaian government to supply 2.5 million COVID vaccines across the country. More on that later. Welcome to all of you, and on behalf of the Rockefeller Foundation, I want to thank you for your commitment to global vaccination access and equity. We are excited to learn from each of you. And in the spirit of learning and collaboration as we move through today's discussion, I'd like to encourage panelists to ask follow-up questions of one another. Hopefully, we can inspire new ways of thinking, share our successes, and reflect on lessons learned. So we'll have a couple of rounds of questions. I'll start with the first one. In recent months, global conversations about COVID-19 immunizations have shifted beyond the topics of vaccine supply and distribution. But I want to take a step back and acknowledge some of the work it took to get us to that place. So Maria, from the Atlantic, I'm hoping you can paint a picture of what the COVID-19 vaccine supply and delivery is like in the Amazon. Are remote groups able to access shots? What are really the main barriers that you see?
Thanks very much. So vaccination in the Amazon region is a massive challenge. We are talking about the largest tropical forest in the planet with an area of 7.5 million square kilometers. About 35 million people live there, including more than 400 indigenous peoples and traditional communities, speaking more than 300 languages. We talk about many common barriers, such as the high cost of vaccination, which is twice as much as in other regions of the same countries, primarily due to logistics with distances of hundreds of kilometers to reach remote communities, for which several days of travel are needed through muddy roads, fast-flowing rivers, or old small plains that rely on good weather, but also because of the problems to guarantee the cold chain for the conservation of vaccines. A critical challenge is the lack of knowledge of the health personnel in indigenous languages and traditions, combined with a lack of cultural adapted information, or the local distrust of government's health services and Western medicine. which feel imposed on their ancestral indigenous knowledge, are hampering vaccination efforts among the indigenous peoples. In the Amazon Indigenous Health Route, we have worked in Brazil, Ecuador, and Peru, as you were mentioning, reaching directly and indirectly more than 340,000 indigenous people. And the barriers and difficulties that I pointed out can apply to all of them.
Thanks, Maria. That was very helpful. And when I look at the experiences that I've had in India, the situation is quite similar. Turning over to you, Gregory, in many ways, pharmacists have had a front row seat to witnessing the vaccine supply challenges we've experienced during COVID-19. How has M-Pharma's work addressed some of these access challenges in partnership with various African governments?
Thank you for the question, and thanks for having me. I think one of the biggest lessons from the pandemic, whether it's from testing to the community response to a lot of the government rules, was that the biggest gap most countries faced was the issue of trust. Low trust in governments meant that most people could not really take any actions that they were told. So people looked to who they could believe. And a lot of research had shown that pharmacists are some of the most trusted healthcare professionals, not just in Africa, but in other parts of the world as well. So we fundamentally believe that M-Pharma, that if we could integrate community pharmacies, which are open early, stay late, to be frontline of access to not only information, but the actual vaccination work, we could accelerate trust in these communities. And our work on vaccination actually began before COVID. We've been building vaccine clinics across our pharmacies in Kenya, in Ghana, in Nigeria. And so we took all that work and we said, how do we do two things? How do we ensure that when vaccines are available, we can become a channel to improve communication about the safety and efficacy of these vaccines in the local communities that we work in? And then two, how do we actually collaborate with the government to build a much more sustainable plan to ensure that as we have new variants and the donor community's attention moves to something else, that we can still have vaccines available so that people that need them can get access to it from years to come. And that's been the work that we've been doing over the last few years across the countries that we operate in.
So thank you for that, Gregory. And what an innovative approach in terms of really using the pharmacists. In terms of the partnership with the governments, did you face any challenges? Was there particular governments where you kind of got an immediate response, with the others you had to really spend a fair amount of time? And also, I'll come back to you, Maria. Was something like this tried out in the Amazon as well?
So, yes, I mean, we face sort of two big, I'll say, if I could put out the challenges in two big buckets. One was that there was a very big mistrust of governments and the private sector. Governments felt very protective of the COVID response. They felt that, everything that had to be done through government channels. And even though the private sector accounts for an increase in share of healthcare delivery in most of the countries that we work in, government pretty much shut out the private sector. And we had to spend a lot of time having to really explain why it doesn't really matter whether the vaccine is given in the public hospital or in the private hospital or private pharmacy. What matters is that the vaccine is given to someone. The channel should not really be the biggest constraint to where you get the vaccine. And it took a bit of time to get the countries like in Ghana that we were much more successful in open up to this idea that yes, the government by itself is not the only provider of healthcare for a lot of these communities. So that was one big challenge. The second challenge was the financing. At the end of the day, yes, vaccines need to get into the arms of people, but it requires health workers to be able to provide those vaccines. And those health workers need to get paid, right? They have families that they need to also sustain. And so it was a big question. If you are going to use the private sector infrastructure to deliver vaccines, what is the type of compensation model that can be put in place to ensure that those health workers that are not being paid by the government, because it's much easier in the public sector, right? Because you get paid by the government. But if you're in the private sector, how do you get compensated if you are, actually providing the service? And we had to actually come up with a PPP, where we brought together a coalition of private companies that agreed to actually put together a financing mechanism whereby they would actually provide the financing that would go to the private healthcare providers that were going to be delivering these vaccines, so that cost does not lie on the government in doing so.
Brilliant. That is so exciting and phenomenal. Kudos to you and the team. Maria, anything you'd want to comment? Did you hear of any similar approaches in the Amazon region?
Well, in the Amazon region, the activity of the private business has not been that big. It depends on the national healthcare systems. But the same issues happened, as Gregory was mentioning, the mistrust on the government policies, on the government structures, on Western medicine, as I was mentioning before. So the reality is quite different because private businesses are not that big here in the countries that we were working in. But the lack of confidence that Indigenous communities and local communities have on the government is a really big issue that we are addressing in the whole region, I believe, not only in the Amazon countries, but in Latin America in general.
Thank you. And, let's delve deeper onto the demand side. Many, but not all low and middle income markets are seeing COVID supply stabilize. In some areas, though, uptake remains slow, and the Rockefeller Foundation is committed to helping in-country partners like Hlabano strengthen regional health systems and generate vaccine demand in order to reach global COVID immunization goals. So, Maria, from your perspective, what barriers do you think we need to address to improve demand and access for vaccine in countries like Ecuador and Peru? How has Hlabano put culture and community at the center of its COVID-19 strategy?
Thanks very much for the question, Deepali. But I think that, as I was mentioning, I would highlight the lack of trust towards the national health systems and the Western medicine, including the fear of vaccines. But the question is, how do you build trust in places where the government has failed? And we have done it based on, and because of time, I'm going to highlight just 3 points among many others. But first is to put the Indigenous voices, knowledge, and rights at the center of action. We took nearly 400 knowledge, attitude, and practices surveys that were completed. These surveys allowed us to work in a differentiated way, and not only by country, but also by Indigenous nationalities. It is sometimes when you speak about Indigenous peoples, you think that they are all the same. Nevertheless, each culture, each nationality has different and important differences, and we have addressed each of them. And although from the beginning we have worked with a comprehensive health approach, we identified through the CAPS surveys that we need to work with a One Health approach also, understanding that the Indigenous worldview does not differentiate the health of people from the health of their territories and their environment. They see it as a whole. And in our area of influence, the CAPS surveys show how, in a 6-month period, the primary source of information about COVID changed from social networks to medical brigades. And in Peru, acceptance of the vaccination in this 6-month period increased from 78 to 91%, in Ecuador from 21 to 73%, and in Brazil, it dropped by 2 points to a final 96%. So all this, even though Indigenous populations continue to prioritize ancestral medicine as part of their identity, now they are open to Western medicine. The second point I wanted to reach is that we built a culturally relevant intervention model, which includes integrated health networks, care protocols, and strategies based on the realities and rights of Indigenous peoples. We develop a series of dialogues of knowledge, a methodology we develop with a gender and intercultural approach in which with the presence of health authorities, UN agencies, and allied NGOs, we collected the concerns of the indigenous leaders and the indigenous health promoters and their fears and proposals regarding vaccines. On the main topics, we proposed workshops to rescue the uses of medicinal plants, and in Ecuador, it led to the creation of an orchard and the support for the Center of Ancestral Knowledge of the Women of Confeniae. Confeniae is the indigenous organization of the Amazonian indigenous peoples in Ecuador. And three, I wanted to point out the importance of culturally adapting the edu-communicational materials. This has been one of the greatest achievements of the project, and we didn't expect that. It surprised us, but we have prepared information banners on the topics prioritized in the CAP surveys, a decalogue for vaccination with cultural relevance, communicational materials to accompany the vaccination brigades, among others. And it was key. For this, we developed a graphic line approved by each nationality. We did a super specific work. And since indigenous peoples have a very rich oral culture, we based our contents on their traditional stories. And this was a success. And the acceptance of these materials has been so great that these graphic lines now are being used by the Ministry of Health of Ecuador, the Ministry of Environment in Peru, or some universities. Some of them are partners of the project, but some are new.
Maria, that is just phenomenal. Just the numbers that you quoted, and where and how far you've gone, that is quite spectacular. As you were speaking, I was also thinking about the India experience. In India, I think what we've encountered was that, women were being left behind. So, the opportunities for the men folk, even in the marginalized communities, as they were going to work, the centers where they could be vaccinated were accessible. But for the women, with all the work that they had to be doing at home, and, not necessarily, it's a very patriarchal society, and not really getting that kind of impetus from the men folk, we felt that, definitely there was the whole gender bias which was coming in. So I'm not sure, Maria, within the indigenous community that you were working with, whether you experienced similar issues that emerged, or probably not. But in India, we really had to have a very targeted approach where we had to really see how we could really ensure that the women could be front and center of any campaign that was being developed.
Same thing happened here, Deepali. And it was really through the CAP surveys, we identified a need of addressing gender issues independently. And that's why in this dialogue of knowledge, we have made a differentiated approach to women. We had workshops just with women to recall their traditional knowledge, their own knowledge, because the use of the plants, the use of the resources of the forest is even different from women and men, but also because in only women spaces, women feel free to speak also. And it is well known that the pandemic has had a big impact in the increase of gender-based violence, for example. And in the Amazon, we also have it is important to make a relation between the gender-based violence and the environmental issues, because of the pressure on the forest and the pressure of natural resources. And that's something that we identified in the project. And yes, we did an independent and a specific approach through a gender approach.
Gregory, if I may, I'll just ask one more question to Maria before coming back to you. So Maria, tremendous learning that you have had as a team. If there was one thing and you had to do things differently this time around based on all the learnings, what would be that one or maybe two things that you would want to do differently?
What we've done differently, that I think that nothing. I don't know, we would have done something different, because one of the greatest things about the indigenous health route is the learnings that we've had through the work we've done. And one thing that we have learned is the importance of walk step by step and make it slowly and stop and look around and see and don't be afraid to get some steps back. So maybe we wouldn't have done anything different, because I think that the good and the bad that we've done are being part of the success that we had also. So maybe it is just the importance of listening to the deep concerns of the indigenous peoples, of local actors.
Yeah, no, Maria, and that really speaks also to the culture and the values that your organization really embraces and reflects in their day-to-day behavior, because, you truly have lived by those values where you're keeping the interests of the indigenous populations front and center, and everything that you designed was around listening to them and the trust that you had built up. So kudos again to you. And Gregory, may I turn to you now? You did mention the public-private partnership and how that helped narrow Ghana's vaccine supply gaps. But you still only have 33% of Ghanaians who received the first dose of COVID vaccine. Why do you think this is the case?
I know this is my sort of unscientific guess. I think, over time there has to be more research done to understand really the sort of the drivers of demand. But in my view, I think there were two big mistakes that we made. At the height of the Delta wave, that is when you had vaccine access constrained. And so right at the moment when actually you could engage people because there was high COVID rates, most Ghanaians didn't have access to the vaccine. By the time the vaccines were widely available, people had moved on to other things. So it was hard to be able to get their attention to say, this is a vaccine that you need, because they said, well, at the height of the pandemic, we didn't get the vaccine, but our lives were okay. Now that there are low cases, why should I go get the vaccine now? I was pretty well, during the high case, nothing happened to me. So I think that was the window that we missed, right? Because if we had the vaccines available at that moment when COVID cases were so high, people were afraid, you would have seen a much higher vaccination rates than you have today. So that's, I'll say, the first big gap that we face. The second part was also when the vaccines were constrained. I think the approach to the vaccination efforts was also very limited. There should have been a lot of preparation that should have gone into really being able to build targeted communities that were most at risk of falling sick. Unfortunately, because of a lack of proper data systems, the vaccines were pretty much available, made open to everyone if you were in an urban area. So most people outside urban centers really didn't get access to the vaccine. And so most elderly people who would have been most at risk and would have actually wanted to actually go for the vaccines didn't get it. We had health workers who were not even getting access to the vaccines, even though they were probably in the highest risk category. So for me, those were the sort of two big, I would say, gaps that we faced. And then finally, maybe that was sort of a lucky thing for Ghana and the African continent in general, is that we did not really face the severity that the rest of the world faced when it came to the effects of the pandemic. Our death rates were much lower, our incidence rates were much lower. So in general, there was a bit of, the feeling that, we are invincible. And if of all the huge cases and the death rates that you saw in other parts of the world, we had such limited cases. And most people actually still don't even know anything about COVID. Most people, COVID is still this imaginary disease, right? We saw in attitudes of people those who had family members or friends who had COVID were more likely to go get the vaccine than those who did not know anyone who had COVID. And for the majority of Ghanaians, they didn't know anyone who got COVID. And so that also affected the drive that would have accelerated demand if most people had known someone who actually had COVID or had been hospitalized from COVID.
But Gregory, you make very good points. Thank you for that. But at the same time, even if within Ghana you did experience cases, but then, the cross-border movements, people coming in and going, I guess there still needs to be, probably from what I'm hearing when you were speaking, was that in terms of just the education around the need for vaccinations was something where probably more could be done to really help people understand that, yes, you're protected right now, but that protection could go at any point of time. Um, do you think, Gregory, there's still a need to kind of really do something more targeted? Because obviously, with 33%, there's a huge risk, right? And you know, you did mention the elderly group, but as Maria and I were speaking, also, the gender bias that came in. From where you've been seeing the situation, are you also seeing that that's kind of been playing out, where the decision making, etc., was not necessary with people who would have come forward? Is there more that needs to be done or can be
Oh,
done?
definitely. We need to accelerate education about vaccination. I mean, the Ghana situation as an example. I still remember that when the vaccines arrived, the first time Ghanaians knew that vaccines were available was when we were told these hospitals are vaccination centers. There was this information gap, no information, no education. All we had was, we have vaccines, show up at this hospital and go get vaccinated. Everyone was like, what do you mean? You can just on a Sunday tell us on a Monday that you can go to these hospitals to go get vaccinated. So there was a huge gap in trying to prepare people mentally to this idea that this vaccine will save your life. There was just this belief from the government that as sort of this elderly or all-knowing figure, the moment the government says do this, everyone will just jump and do it. But I think the vaccination rates really showed that people don't really trust the government, to the point that when the government says do this, people just jump and do that. So that was a huge gap. And I think that we still have that gap up to today. I mean, the number of conversations I even have to have with friends who are very educated, but still have all these conspiracies around COVID vaccine. It's insane. I mean, it's just mind-boggling when you actually have to listen to these conspiracy theories. And because those conspiracy theories were not counted with actual real world education, I think it's done more damage. Not just damage to COVID vaccination. I think it's done more even damage to vaccinations in general, where people are actually more afraid to even go for any other vaccines out there. And I think that could be a very difficult legacy of COVID if we do not accelerate efforts to actually educate people about the safety and the reason why you should actually go get a vaccine.
Thank you, Gregory. I'm going to push a little bit further on that. If you were really the Minister of Health in Ghana, Gregory, what would be the 2 or 3 things that you would want to do? Because, as you're saying, there's so much of, debunking of the myths, etc. But you really were in that position where you could really make change happen. What do you think would be the 3 top things that you'd like to do?
Well, if I could, hindsight is it's always great. So I try not to criticize people for past decisions that much, because I guess when we're in the heat of the moment, it's hard to know the decisions that we are making, the consequences that they would have. But I mean, the first thing I would do is to really be very, very targeted. I would have focused on targeting high risk populations. So, for example, we know that people with chronic conditions, diabetes and hypertension, had a higher risk of morbidity from the pandemic. Immediately, I would have made sure that in pharmacies, in hospitals, when people are going for their chronic diabetes clinics or hypertension clinics, those are the people where we would integrate vaccination into their regular screening on day one. I mean, we had limited vaccines anyway when we started off, and I would have targeted those vaccine doses that we had on those specific chronic clinic, which almost every hospital has. Most pharmacies, people go refill their chronic medications. Then those were the people I would have targeted on day one. The second thing would have been utilizing spiritual, the churches and the mosques and the traditional rulers as sort of my education center. At the Friday mosque prayers, on Sunday church service, I would try and get every religious leader to spend 2 minutes. In fact, I had proposed that we should actually have vaccination sites at church. Have the priests, the pastors, the imams take their fair shots in front of their congregation to begin to actually build trust in it, because people have a high level of trust in religious leaders. And I would have used them as an example on day one, where we would have vaccination centers in those churches and actually have them be at the center of taking those first doses when that happened. And then finally, and wearing my private sector hat here, I would definitely on day one, would have made sure that the private healthcare providers played a critical role. Because at the end of the day, when you compare trust in the public health system to trust in the private health system, I would say there's a higher trust in the private health system than there is in the public health system. And yes, whilst that also means that there's inequality in between those that can access the private health system to those that can access the public health system, at least if we could begin to leverage a private health system, have people who are used to getting healthcare in public hospitals say you can go get your COVID vaccines in the private health system, where there's a high level of trust. It's aspirational for people to say I can go get healthcare in the private health system at no cost to them. I think that would have helped also improve the trust that people have in the actual delivery mechanism. So those are the three things that just myself as health minister would have probably done.
Brilliant. And as you said, I think every government was really trying to do its best in that moment. It's so easy for us to say, well, this could have been done better. But, in that moment, every government really tried, and, phenomenal recommendations, because obviously, with the kind of deep insights that you have, I really like the way you framed the three responses. So thank you for that. Moving on, COVID-19 has illuminated health disparities the world over. The pandemic has really taught us and continues to teach us critical lessons about global health collaboration and the need for robust, agile health systems. In turn, many agencies are weaving the values of fairness, representation, and inclusion into their vaccination campaigns. So, Maria, your work with the Amazon Indigenous Health Route also centers around this cultural approach to global health. How has your team operationalized the concept of vaccine equity?
So thanks for the question. And we have bet on something that at first may seem like an oxymoron, and it's to provide Indigenous peoples with access and training in the use of technology to strengthen their ancestral knowledge. Among others, we have developed an app, ComCare, used by the health promoters to strengthen community-based surveillance. The app allows us to identify suspected cases of COVID, record vaccination, or detect other diseases, and this to promote the sovereignty of Indigenous data and its use by the Indigenous organizations. We believe this is a field with a lot of potential and not an easy issue because of the lack of connectivity in the Amazon region or the lack of technology knowledge that Indigenous peoples, especially far in communities deep in the forest, have. But we really believe that putting the attention on technologies is a must for the Indigenous communities. We have also developed interactive maps for access to local public health services, which showed the gaps in the access to health. It was impressive because the health providers, the government, didn't really know how to reach the communities. Since they are so far, they thought they counted like the kilometers between the health, the big cities, for example, to the communities. They said, okay, it's 50 kilometers away, but they didn't count on that. Through these 50 kilometers, you have to go by river, then you have to walk for 8 hours deep in the forest, then you have to take another river. So we really work hard to identify these health routes. And we defined 18 Indigenous health networks one by nationality and by country, and 118 micro networks to really understand the territories and the difficulties of for not only the health promoters to get or the healthcare systems, the government to get to the communities, but also for the indigenous peoples to get to the health establishments. We have also installed 10 telemedicine networks, which have been like a super success. Internet points for telecommunications powered by solar systems, solar energy systems. We have developed 2 online courses with the universities in Ecuador and in Peru for our indigenous health promoters. More than 140 health promoters organized a rich multi-actor regional community of practice, and we were meeting monthly by Zoom. So we really needed to introduce the people who participated in this community of practice to the use of technologies too. We have supported communication campaigns through the indigenous radio stations, and all of the products that we developed by the project are available to any person on an online platform on the All Eyes on the Amazon. In short, and because it's more activities that we've done, but we've developed a diversity of actions to promote civic rights, and especially those related to health in this digital age. So we think that we had like a really different approach through the use of technologies with indigenous peoples.
That is excellent. Maria, in terms of the government embracing these technologies and these apps that you've developed, what traction are you seeing?
Well, the app is for the use of indigenous peoples, not for the government, because we really believe in the importance of the indigenous organizations to manage their own data, to manage independent data. This is why, because the government went to the communities and take samples, get back, and the communities didn't know nothing after that. Also, the universities, they went to the communities, they took samples, get back to the labs, and the communities don't know what happened with that information. And there is a lack of information regarding vaccination here in the region, really, really important. You don't have information not only on what happens in the Amazon, but we really don't have trusted information on how vaccination is moving at a national level. The ministries of health, the government is not opening that information to public. So if you don't have that at a national level, you don't have it at an Amazonian level, you don't have it at indigenous community or indigenous nationality level. So for us, it was really, really important for indigenous organization to know what is happening in their territories, to know what is happening in each community, and to take political decisions on that information. So we are talking about indigenous data and sovereignty, and how each indigenous organization, indigenous nationality want to use that information and for what. And we are advancing on it. Is not easy. The use, although we've done the app is adapted culturally, and that's been a super effort that we've done. We have tested it with our health promoters at a community level, but it is still, really, well, we are working on it, but the interest on the app is huge. We have organizations from Brazil asking us to use it, from Ecuador asking us to use it, and it's been great because Rockefeller has supported us to open the use of the app, and that is what is for it, but to continue working with it through other organizations, through other cooperation agencies. So the interest of developing new technology adapted to indigenous peoples is a must here in the region.
No, thank you, Maria. And, for Rockefeller Foundation, we're a science-driven philanthropy. And for us, the use of technology and to put it in the hands of people who really need it the most and can make all the decisions themselves is just, core to everything that we do. So thank you for all that you've been able to do. Gregory, turning over to you, pharmacies often act as frontline vaccine suppliers in areas with limited healthcare coverage. How might the principles of vaccine equity also apply to routine immunizations?
Yeah, about a year ago, we did a survey in Ghana. We asked our patients between a pharmacy and a clinic or hospital, where do they spend most of their time? 55% of them picked a pharmacy. And so at the end of the day, our belief is that if we can take this trusted channel that people already rely on, it's the most affordable healthcare channel most people know of, because the primary mode through which most people get access to primary healthcare in Africa is through self-medication. If we can take this channel that people trust, the pharmacist is normally called the community doctor, and begin to expand the clinical capabilities that space and healthcare provider can give to the community, then we can actually accelerate much more equitable access to healthcare, regardless of whether I have a big hospital in my community or a fancy clinic in my community, because there will always be either a pharmacy or a health shop in that particular community. And so for us at M-Pharma, we continue to invest in expanding those capabilities within the pharmacies that we are invested in. We've invested in over 515 community pharmacies and health shops across the continent, delivering medical care to 250,000 patients each month. And we want to continue to invest in that channel so that the capabilities that each of these pharmacies have, and hopefully if we can make sure that every community in the countries that we operate in have access to a pharmacy that we've invested in, then we can actually leverage those channels to do more than even vaccination. Really build a basic primary healthcare infrastructure for those communities that are most often left behind.
Gregory, that's so important, and I think, we all have to be better prepared for future pandemics. So if we can really start at that community-based level and really have the pharmacies who are really equipped to deal with all the challenges that are going to come down with climate, we know the kind of health crisis we're sitting on. It is so important. Please go ahead, Gregory.
Sorry.
Please go ahead.
I was going to say, if I may add, and I think it's a very important point that you just raised. I've been in a lot of discussions where people ask, how do we prepare for the next pandemic? And there's a big focus on how do we build the data infrastructure so that we can begin to catch the next pandemic before it becomes significant. And I always tell people the next pandemic will rear its head in a pharmacy first. Because when people start having the symptoms, that cough, that flu, they don't walk into a hospital to go see a doctor. They pop into a pharmacy and they say, I have a flu, I'm coughing, and then they get medications. In fact, one of the important assets that we built in Ghana, once the pandemic started, our clinical team picked 300 drugs that people would use to self-treat symptoms of COVID. And we took historical data on what was the dispensation rate of those drugs pre-COVID. And then we gave this real-time dashboard to the Ghana Health Service. And we said, if you probably see a lot of people buying these medicines at a higher rate than what they used to buy pre-COVID, you should probably go do spot testing in these communities. And I kid you not, almost 2 weeks before the government will announce a new wave of COVID in Ghana, we could already see that in our data. Because patients were walking into our pharmacies thinking they had malaria. In fact, at some point, there was a joke in Ghana, whenever there's a new wave, we call it the malaria-demic. because people be treating themselves for malaria when it's not really malaria, right? Because they had the same symptoms of COVID. So really, from a data architecture standpoint, I fundamentally believe that we need to meet patients where they go to as the first line of care. And that first line of care is their community pharmacy, is their health shop, ADO, wherever, whatever in the country it's referred to. And if we can begin to integrate the data from these pharmacies, from these health shops into the national reporting systems, then that is how we can start preparing for the next pandemic, because then we can catch these interactions early. And by catching it early, we can respond much faster.
That is such a fantastic point, Gregory. And, we've been investing on wastewater surveillance and looking at, what, we can pick up from there in terms of the pandemic prevalence. But, I think very little work, to the best of my knowledge at this point of time, has been done just around, really tracking the data that is coming from the pharmacies, especially in South Asia as well. Everybody self-medicates themselves. They just go to a pharmacy before they go to a hospital and just buy medicines. And if you really analyze all that and track that carefully, there'll definitely be very, very important insights that could really help us better prepare for any future pandemic. So thank you for that. Before I move on to the final question, Gregory and Maria, both of you have made such phenomenal points. Do you have anything that you want to, ask each other? Because I just wanted to give you that opportunity. It's just been such a rich discussion.
I took a lot of notes of what Gregory was mentioning. So yes, but I just wanted to mention how we agreed on some points, and for me it's really important to address the lack of confidence of people in the national health systems. How we address that, and Gregory was saying, it's not that just because the government tells you come and vaccinate yourself because we have the vaccines right now, is that people is going to go and do that. So how do we have governments that are trusted by their people? And that's a huge social improvement that we have to do, because at the end we decide who is in our governments, isn't it? But it's a responsibility of all of us. But we also agreed in the importance of a culture-based approach, and I think also a rights-based approach, isn't it? But one thing that also Gregory was mentioning is, and I want to make a point on this, is who takes care of the healthcare providers, because they are key. In our case, we can say that a healthcare provider is the community health promoter that we are working with. So, and they have a voluntary work here in the region. They are one of the things I wanted to say is, and Gregory, you were also mentioning this, is the importance of trusted people in the communities. You were mentioning the religious leaders. In our case, are the indigenous leaders, but also the indigenous health promoters. And when for us, it made a difference in the program, in the project, when we went to vaccinate the leaders, and we went to vaccinate the indigenous health promoters. And when the rest of the community saw that they got their vaccines, they went after them, and they were open to the vaccines, and they trusted the vaccination process. But also another common issue is the conspiracy around the vaccines. We call it, we say here that we have an infodemic around that. And we address that, Gregory, through these knowledge dialogues. With the CAP surveys, we identified that problem. For example, here, for many indigenous communities, if you got the vaccine, you were going to lose, men were going to lose their viralidad. I don't know how you say it in English. Sorry. They were not going to be able to have sex relations, for example.
Yeah.
So, or they were going to lose their soul. Or it was a trap, so they were going to lose their power, no? So there were a lot of things going around. For example, women were not going to be able to have babies, to get pregnant. So there were a lot of information around the vaccination, and we went to the point. If this is what they are worried about, we're going to address it. So we weren't afraid of addressing the issues. We really were really frontal to it. And also, well, the importance of the government data infrastructure, Gregory, as I was mentioning, is a huge necessity that we have here in the region. And I took this idea of being really aware of what is happening in the pharmacies. I agree with you. In the Amazon, the reality is that at the community level, they don't have pharmacies. It's just in the big cities. But it's really a really brilliant idea you have on that. So yes, maybe Gregory, I want to ask you regarding all these issues. How have you addressed this conspiracy around vaccines at the end? What do you think was your biggest success regarding that? And regarding getting the confidence of the people, because I think that was at least a main issue for us.
Yeah. To be honest, I actually, that was the question I was going to ask you. We've not been successful. I don't think that, I have a data point that I could point to say, this shows that we've been successful. What we just have done is that we used all our pharmacies, hundreds of pharmacies, to become information points. Whenever someone bought something, we'll put a leaflet in their package that had information about COVID and the vaccine. But I can't sit down and say that they were successful or not, because I think that even with just my friends who are very educated, if they are telling me those things, I don't think that I've been successful in changing everyone's mind. The only I'll say probably success was my own family. My parents were very old, and are the ones who are more likely to be, who are more likely to be won over by conspiracies. I think, when I, as their son, spent time talking to them about why they had to take the vaccines. In fact, when the booster shots were made available, I thought I had to convince them. Then my mom called me and said, "Oh, they've already gone for their booster shots." I was calling to remind me that I should go for my booster shots as well. So I felt good about it. That, oh, wow, actually, when it came for boosters, I didn't have to actually convince them to actually go get the boosters. So I'll say in my own family, that would be the success. And it just took the relationship of a son and mother and father to get them to believe that. And I think probably that is what would allow us to address conspiracy, that personal relationship. If you have someone who you trust and that person speaks to you about something, you will listen to it. But is there like a broad campaign that I think can be done? I don't know. I think the conspiracy theorists were pretty fast and they quickly won people's minds. And I think it's going to take a lot of work to really be able to break that cycle for most people. I think it's a tough work that has to be done.
Thank you so much. And, you've actually answered the last question that I was going to pose to you. But clearly, the aspect of trust being so fundamental in terms of anything and everything that we want to do, the role of data and technology, the need for collaboration. None of us can do it alone. How do we really pull in the private sector, the public sector, the civil society organizations, and most importantly, Maria, as you said, keep people at the center. Whom are we really trying to serve? How can we really start with where they are? And if they have some misconceptions, let's address them head on rather than keep pushing it under the carpet, because they'll surface again. So as we approach the end of our time, I want to thank both of you for the work that you're doing in this area. Take time to reflect on your accomplishments, but don't stop fighting. There's still so much work to do to ensure every community is protected. It is our privilege at the Rockefeller Foundation to support champion partners like yourselves to inch us towards solutions. I'm excited to note the pathways to learn, collaborate, and unite across borders when faced with the grave challenges of our times. And know that the lessons we learned today, the knowledge you've shared today, will prepare us for the global health challenges of tomorrow. To those of you viewing this episode of RF Breakthrough, we thank you for tuning in. We encourage you to continue the conversation and engage with our panelists using the RF Breakthrough hashtag on social media. If you enjoyed this conversation and want to see more of these discussions, Visit us online at rockefellerfoundation.org/Art of Breakthrough. Thank you so much.